Hi, everyone. I'd like to welcome everybody tonight, and this is a big step just to get people out to listen to these talks. We really strive to get the word out, and the biggest thing with concussion management is education, and it's education from the physician level all the way down to the athlete themselves. And as parents, and some of the kids here too, but as parents, it's really important that you guys have at least a little bit of an idea of what is a concussion, what are the signs, what are the symptoms, because a lot of these kids are in sports or even not even in sports. We've had some of my most difficult concussions are kids that slipped on the ice or got hit with a car door. So you're the front line. You're going to see your kids, and you have to. You're the ones who identify they're a little bit off. They're sleeping too much. They're teenagers. They sleep all the time anyway. So like, what is too much? So I'm glad that the parents are getting involved here. Bill Mills is doing a great job here to try and push the forefront of concussion management. And I am fortunate to be invited to talk tonight. And I have a couple slides. I'm going to try more to just kind of talk one-on-one with you guys, but I will refer to a couple slides, a couple boring slides, because I really want to hammer home some of the ideas of concussion. So I'm going to try and make it as fun as possible. I don't have any really cool slides. So concussion numbers are very difficult to come up with. So just some of these numbers here, the CDC estimates like basically 1.5 to almost 4 million concussions a year. You probably could double, triple, or quadruple that number because, as stated here, a lot of the kids don't know that they have a concussion or signs of concussion. A lot of the kids know but don't want to tell the coach or the trainer because they don't want to come out of the game. And there's other, sometimes a secondary game, it's a championship game, they don't want to come out. So there are so many reasons that we probably underreport concussions. Coaches are getting better. One of the biggest battles about 10 years ago when I started was that we would identify a concussed kid and on the sidelines of a Friday night game or Saturday afternoon game, and the coaches are riding you and riding you and riding you, because a lot of these concussions, the symptoms resolve in 10, 15, 20 minutes, and the kid looks fine. The kid's arguing they want to get back. The parents are arguing they want them to be back in the game. So over the last 10 years, we've seen the pendulum swing a little bit with education, that the coaches are now on board with the medical decision-making teams, and the parents, for the most part, are coming around. They may not be happy about it, their kids being held, but I think when we explain the downside of them playing through the concussion, most of them can see that that is a good thing. There was a study, high school football, where they did through questionnaires, they found that only about less than half the kids actually reported their concussion. And these were kids that they suspected they had concussion. They knew that they had some dizziness or blurred vision and said that they did not report it to the trainers. 66% that they didn't realize the symptoms that they did have were concussion. And this is the big part here, that half of them wanted to avoid being held out of competition. And that's the biggest battle. These kids are athletes, they're driven. They don't, your sons with the ankle sprain or whatever, they want to play through as much as they can. So it's the athlete's mentality that we have to, kind of work with. Of course, some of the risk factors are pretty self-explanatory. The contact and collision sports, definitely higher yield for concussions. But we've seen cross-country kids that have no bodily contact. They'll slip on a rock, fall back at their head. So I think as athletic trainers and physicians, we have to also realize that it can happen in those other sports. Sometimes we have a tendency to we poo-poo that a little bit too, but we step back and identify the kid and the symptoms, and not necessarily just throw them into it. It wasn't a football or it wasn't lacrosse, so it's probably not concussion. Risk factor of a previous concussion, and I go through this speech with all the kids that we work with. If you have had one concussion, no matter what the situation was, whether it was sports or non-sports related, you are at a higher risk to get another concussion. And if you get a second concussion, you are at logarithmically more risk of getting the third, and it keeps going up from there. So that's the big thing that we do know, is that if you get more concussions, you're more susceptible to even more concussions. And you see that with the Eric Lindros family and, stuff, dating myself a little bit there, but they had those multiple concussions and they just got them easier and easier and easier. We really, if we identify a team, say football or lacrosse, that has a couple concussions, more in practice, we kind of step back, look at the coaches and say, what drills are they occurring in? And that's what Bill Mills is going to be working on here, is to figure out, is there one specific drill that is producing a lot of concussions? Is it a technique issue? Is it an equipment issue? So I think that's important as we go forward to try and identify a risk factor of a drill, maybe modify the drill or, work with different equipment modifications to try and decrease the risk. Genetics, we're, just touching the tip of the iceberg with that. We really don't know much. There are a couple things out there in the literature that are stating that we definitely I see families with concussions. So there's got to be something with the genetic component. They've identified a couple markers that are, they're doing some tests there. Nothing's been, 100% proven to be a risk factor. Every 4 years, they have international conferences where all the experts from the world come together and they sit around a big table. I would love to just go to that and just listen. And they have, it's a state of affairs. It's like the State of the Union for concussions, pretty much. And these slides are going to be a little wordy and a little boring, but I actually wanted to include them because it kind of I've been following it since 2004. So every time they do it, they spend so much time on the wording with this, and the wording has changed with each conference. So every 4 years they redefine what a concussion is. So for the next 4 years, a concussion is a brain injury, which is defined as a complex pathophysiological process affecting the brain induced by biomechanical forces. That's a lot of words. Essentially what that means is that it doesn't have to be a direct blow to the head. It just is some kind of injury, some kind of quick motion where the biomechanics of your body move in the way that it gets the brain to be slightly injured. Point number 2, several common features that incorporate clinical, pathologic, and biomechanical injury constructs that may be utilized in defining the nature of concussive head injury include. I'm just going to go through a list of some features here that, getting back to my point before, concussion can be caused by either a direct blow to the head, face, or neck area, or elsewhere in the body. And that is going to be, we're going to try and play this video right here and show how that's possible. We've had kids get concussions by coming hard off a basketball pick. They basically just run into another body, shoulder-to-shoulder contact, and it's like a whiplash type thing. So this will demonstrate the flexion extension of the neck, which could be really any injury here. And then this is showing the brain's movement inside of the skull. And you can see that the brain does not move exactly with the skull. It has a little bit of inertia and momentum. And you'll see that there's contact points where the brain hits the bony anatomy. And I can play that again. Maybe. So you get the brain centralized there, and then the impact here, and then it comes back and hits the front. So every quick movement has usually 2 impact points. In this case, there's a posterior and an anterior impact. And that in itself can cause specific injury to those parts. Also, you can get injury to other parts of the brain just from the motion, that the neurons can be slightly stretched or compressed. So it doesn't have to necessarily correspond with the impact points of the brain, but it's a good graphic to show that it is really the movement of the head and not necessarily an impact to the head. Let's see here. Okay. Point 2, concussions typically result in the rapid onset of short-lived impairment from a neurologic function that typically resolves spontaneously. Like I said, a lot of times we'll have these kids that clear in 2 minutes, 5 minutes, 10 minutes on the sideline. However, in some cases, the signs may evolve over a number of minutes to hours. And I think that point's important too, because, as Mike and Bill can attest here, we'll see a kid, we see a tremendous, lacrosse hit or football hit, and we'll pull the kid out, and they're fine, and they test fine, they look fine, they say they're fine, and then you just wait a little bit. If your suspicion's high, because what will happen is sometimes the symptoms won't be instantaneous, and you've seen this with the past couple of years with the NFL. They've put some of these guys back in and then pull them out a couple plays later. So what we try and do is if we really have a high suspicion of some kind of injury, we'll sit them out a series and watch for 5, 10, 15 minutes. And, if really nothing's developed over those first couple minutes, it's probably safe to put the kids back in. But I've had a couple where I was, testing them up and down, questioning, physical examination. Kid looks fine, 5 minutes, 8 minutes, 10 minutes, and we're like, well, this kid looks pretty good. I'm like, let me just go check him one more time. And then all of a sudden, I touch him with one finger, he just falls right over, the balance is gone, the crushing headache comes. So, that's a kid that if we didn't take our time and wait for those symptoms to evolve, we may have put that kid back in a game. So we've gotten a little bit better about waiting it out. And again, that's where the education with the coaches and the other players have helped us to buy a little bit more time on the sidelines without having everybody chirp at us. Number 3, the concussion may result in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than structural. And that's big. Everyone wants to go and get a CAT scan of the head or an MRI of the brain, and 99.9% of the time those are normal because it's a functional disturbance and not something that's a structural bleed, brain contusion sort of thing. So, most times these images are totally normal, but the kids have tremendous symptoms, and it's a functional problem more than structural. Number 4, concussions result in a graded set of clinical symptoms that may or may not involve loss of consciousness. And that part of the education is getting out there. Everyone thinks you have to lose consciousness to have a concussion. And we're getting out there and trying to tell people that that's not the case at all. So that we even get that with people that come in and they say, well, I probably didn't have a concussion, because I didn't lose consciousness, but I've had a crushing headache for the past 2 weeks and I can't look in the lights. So it's still not out there. Resolution of the clinical and cognitive symptoms typically follow a sequential course. However, it's not perfect. So sometimes some symptoms will resolve first, leaving you with traditionally some other ones. I'm just going to go through some of these symptoms, and it's not to belabor the point, but I've had probably concussions with just one of these symptoms, which could be irritability down here at the end of the list. So, mom or dad comes in and says, it's just been irritable since then, and that could be a concussion, even without the headache and everything. So the main ones that most people know, headache, pressure in the head, neck pain, that's more from just the local trauma. A lot of the neck stiffness, people are writing that off, but a lot of times that could be concussive. You could be getting headaches that are radiating down too. Nausea, vomiting, dizziness, quite common. Blurred vision, you'll see the guys kind of shaking their eyes, trying to get that fog off their eyes. Balance problems, like I referred to before, a lot of these kids, most of our athletes are very good with balance. That's what a lot of our preseason training is doing. So if we can even find some subtle decrease in balance, that's probably significant for these kids. The sensitivities to noise and light, a lot of times we're sitting in front of the band and, you see these kids and they're just, on the sideline, just like cringing because they're hearing the band, the tubas, and the drums. Feeling slowed down, feeling in a fog, not really sure why they break this into 2 symptoms, but sometimes the kids will relate to one and not the other when we're asking the symptoms. not feeling right. Some of the kids will just come in and say, you know what, can't put my finger on it. I haven't been clear since the game on Friday. Difficulty, this is more to the school, difficulty with remembering, concentrating, staying awake, staying energetic for the class period. Confusion, drowsiness, they're pretty obvious to most of the people in the room. Trouble falling asleep. Sometimes we've got these kids that want to sleep 18 hours. Sometimes we have the kids who feel tired and they lay in bed and can't fall asleep. The emotionality, irritability, these kids that are all of a sudden crying on the sideline for no reason, or crying at home when they're not crying kids. Anxiety and nervousness. Sometimes that's peaked. It's a little bit worse with the kids that have a little baseline anxiety issue or like an ADHD or something like that. But it could be in a kid that doesn't have any previous symptoms also. Initial treatments are, basically make sure that the kid's okay. This is stuff the athletic trainers learn in first year. We learn in the first year of medical school. Make sure they're breathing okay. Make sure it's not a cervical spine injury. Make sure we don't have to put them on a spine board and get them out. And that's easy at the high school level because there are athletic trainers and physicians. But most of these happen in situations where there are no trainers and there's no doctors. It's the the Pee Wee League football or the gym class. So the more we know about this and spread the word, the better it's going to be. In a football game, you don't want to remove the helmet because we've got a set of shoulder pads on. And what would happen is if we're evaluating somebody and you go to take the helmet off, your neck falls into extension. And if there was a cervical spine injury, that would make it worse. So that's the one thing that even a lot of you will be, now the experts at the field for some of these junior events, just keep the helmet on. We've finally gotten through to the EMS team, I think. I don't know. It's been several years, but because motorcycle accidents, they want to take the helmet off because they don't have shoulder pads, they're putting the head into flexion. So we have fought with them for years. I think we finally educated them enough where most of them let us run the show with that. There are different sideline tools out there. There's different questionnaires that we ask the kids. There's different physical exam techniques. And the SCAT-3 is something that's been developed at those international conferences, and I'll touch base with that a little bit in a second. Basically, 98% of the concussions we treat, we probably don't need to send to the ER. We kind of watch them on the sideline, make sure everything's okay. You want to watch them longitudinally over the 30, 60 minutes, and a lot of times after the game they go up to the training room with the trainers, and we get to see them for a while. If anything worsens, there's a neurologic finding that doesn't make sense, then I have a low threshold to send you to the ER. And if it's that one person that needs to be CAT scanned, we would want to make sure we don't have a bleed or something more serious. What's changed over the years is return to play. Even when I started, I was trained about 15 years ago, we looked at the kids, we watched them, and if they had concussion symptoms, dizzy, headache, if that resolved in 15 minutes, we put them back in the game. That was the standard of care at that point, which kind of scares me now. But right now, if they've any of those concussion symptoms, any high, even kids lie too. So we basically, even if we have a high suspicion that there is something going on, we'll hold them out for the game. It's just the safe thing. It's the pro and con. It's just not worth it to put a kid back or an adult back in a situation where things could potentially get worse. Follow up, and again, I'm just going to touch a little bit on this, and I'm going to turn it over to Mr. Mills and Brenda to talk more about what we're going to do for the longitudinal follow up. But basically, complete physical and mental rest. The physical rest is pretty easy. We take them out of gym class, we take them out of sports teams, and a lot of times we do. I like to remove from the school too. They don't have to get up; they can sleep, so we can kind of really shut the body down. The mental rest is pretty tough. These kids, especially in Malvern here, it's a pretty rigorous curriculum. These kids are really focused on their grades, so it's really difficult. And a lot of the kids don't want to get behind with their studies, so we really have to balance the mental rest and the kids' desire, sometimes the parents' desire, to keep them up with their schoolwork. And I'm going to defer that discussion to later. Over the years, things have changed. The PIAA handbook is updated, I think it was a year ago, where they vaguely say that the kid needs to be cleared at the PIA schools by a physician who is comfortable with the current state of affairs with concussion management. They don't say what that is, but so anybody who claims that they know what concussions are, I guess, could be okay. The SCAT-3, I don't think you can read that, but essentially they go through a couple things. This area here is some basic questionnaires or the basic evaluation of anybody who would have a head trauma or unconscious. This area here, and I'm sure, Mr. Wells, we've used to use these individually through the years, and now they've just tried to incorporate it all in one area. These questions here, what school are you playing at? What team are you playing? Without looking at the scoreboard, what's the score? Like some of those questions that kind of get your orientation. Symptoms, those same symptoms that we just listed are all here. So we ask the kids right away on the sidelines, do you have, headache, pressure in head, neck pain? And they rate them on a 0 to 6 scale. Over here, we do a little bit of work with, again, some orientation. What month is it? What date is it? To kind of see where they are mentally. Down here, we give them some words to remember, usually 5, 3 to 5, but in this case, it's 5. And then we have them do it 3 times, and then we wait about 5 minutes and then give them to them again to see their delayed recall. And this is more for concentration here. We give them a list of numbers. We'll say 1, 2, 3, and then give us the numbers in reverse, and the kids have to digest that and say 3, 2, 1, and then we increase by a number. They're really, they're hard to do without concussion sometimes if you're not focusing. So we get a sense of where they are, and it kind of lets us know if sometimes they look and they don't even, you can tell that the cogs are not even spinning. So you can kind of, when I do these, I'll say, they got, 3 digits right, 4 digits right, but not the 5 and 6. But I'll also say they tried hard on the 5 and 6 because you could see them. Maybe they flipped one of the numbers, but they were at least giving a good effort. And then we go into the physical exam. We do the neck exam, of course, then balance testing. We do some, feet next to each other on one foot, kind of seeing how things go, eyes open, eyes closed sometimes. And then we give some athlete information here. Basically, and I think you guys even have like the handouts to what to look for overnight when we send the kids home, or at least if there's not a handout, most of the athletic training rooms have at least some kind of protocol. They'll tell the parents, they'll tell the kids, and kind of make sure you're coached on what's going to happen over the next 24 hours. And then we're pretty much all using the same return to play protocol now, which basically takes a lot of the guesswork out. We used to all have our own recommendations. There were a bunch of different protocols out there. The Academy of Neurology had one. The Academy of Pediatrics had another. The sports medicine associations had different ones. So now we've kind of all settled on the same return to play. The number one priority is you have to be completely asymptomatic before we start the progression. And then there's different levels. Each level is about 24 hours. You have to wait 24 hours to move. So in the beginning, you start with something easy, which is stationary biking. Biking will get your heart rate up but not move your head. If you do okay with that, then we start to add some motion. We'll do some walking and jogging, which is getting your heart rate up but moving your eye level and moving your head. And then we do some practice skills, and then we put you into a practice, and then we put you into a game. So we just, it's pretty standard, and it's for any sport. We don't cut any days out, so, and it always gets difficult because if, the Friday night game would be the day we would practice, could we do that instead of a practice? And it's just too regimented, and it's not worth skipping a day on this program. So we're all pretty much on the same page with that, which has been really nice because we can just hand this to people now and say, this is what it's going to be. You're asymptomatic on Wednesday, then this is your Wednesday plan, this is Thursday, this is Friday. And if we don't go according to plan, then we just stop, reassess, and kind of keep going. So we don't have to go back to the beginning all the time. We have to wait 5 days to start the process again. So it's easier to tell kids and parents what our process is going to be. They've developed one for the kids. The big difference is the questions. I can't even see it on mine, but have you had trouble paying attention? Do you forget things? Do you feel dizzy? Do you see me as 2 people instead of 1? So it's like putting it in younger kids' words as opposed to some of the ones that were asked before. Same return to play. The one caveat is that the younger the person, the more conservative we should be. All the literature out there says that, we get these 8-year-old, 9-year-old, 10-year-old kids. The brain is much more malleable and susceptible to re-injury. So that's where I think the future is going to be. I think we're going to come up with a different protocol for return to play for the younger kids, because I think we should be a little bit more conservative than we have now. And I take that into account too. So we kind of see where the kids are age-wise, grade-wise, and I might add a little extra healing time for that. And again, I think that's going to be probably the next conference in 4 years. Again, that's the return to play protocol. A lot of the schools, including Malvern, using a lot of the computerized testing to do baseline tests for the kids, and then if we happen to have an injury, we test them after the injury. Impact is one, concussion vital signs is another program. They're basically just geared at doing the same thing. We're trying to get a functional assessment of where the brain is. And if you go back to one of the early slides, because this is not structural, it's more of a processing issue, it's more functional. CAT scans, MRIs, all the studies that we have for other like bone injuries and fractures don't really hold up here. So we've been really successful at trying to take something that we can mass produce and test 400 kids a year, and at least it gives us a tool to see where the processing speed is, where the kid is. Because a lot of times, I think they look good, they examine fine, the balance is good, the parents think they look good, and we put them on these tests, and functionally, they're not there at all. And it's nice because, again, that's one of those kids we might have cleared for contact, and that brain just isn't healed yet. And a lot of times, you give it a couple more days, a week or two, whatever it would be, and you watch those scores come up. So then we know that the last piece of the puzzle is back. We don't base all of our discussions, just on that, but it's a really valuable piece that we haven't been able to put our hands around until now. So it's been great. They've been big. 5 years, maybe, I guess we've been doing it here. We're at least getting everybody baselined, and that's nice. Kid at a computer, but basically the trouble with schools is, how do you test all these kids? A lot of people, preseason baseline, I think it's neck tissue, they'll put you in a big computer lab, shoulder to shoulder with somebody. You hear keys clicking and popping and noise and people, sneezing. So how accurate is the baseline? So we're always trying to make this thing better. So we're trying to, keep the environment good for testing. A lot of times in the computer lab, you'll do every other kid staggered so that the noise isn't that bad. A lot of times you don't let the kids get up until everybody's done, so you don't hear the noise of the kids leaving early. So we're trying to make it as reproducible as possible going forward. Just a sample picture. You're trying to do things as fast as you can. There's designs, there's shapes, there's things you have to memorize. Did you see the shape before? So it's a difficult test. So, even the adults here, if you have a chance to take a baseline test, a lot of offices offer them for $20 or something like that. You never know when you're going to get a concussion, so it might be worthwhile just to see, what the kids are doing, but also it's always nice to have an adult baseline too. Education's the key. I'll come out, I'll talk to 2 people, I'll talk to 200 people, just to get the word out. If we can educate, 10 people tonight, and those 10 people start to tell people, it just snowballs in a positive direction. So you can always ask Mr. Mills for my contact information. If you have a small group, like a small hockey league or football league that wants to talk about concussions, feel free to just let me know, and we'll do the same thing. I'll do it at a smaller event. This is such a beautiful place, but I'll do it at a locker rooms. We do it at ice line, rinks and stuff like that. So whoever would want to learn about this, just please pass my name along. Oops. And I will now turn it over to Mr. Mills.